All right,
Thanks.
so we've got about 15 minutes for discussion, and I also want to open this up to the audience. So anybody who's got a question, come up to one of the mics. But let me start. And so I've got a great panel here. We've got Azeem Latib here as well from Montefiore. So Azeem, let me ask you, you do a lot of acute infarcts. What do you see as the challenges? How often do you see either no reflow or slow flow, at least that you can honestly identify? People often overcall what TIMI 3 flow is. We won't get into that. And how do you prepare the vessel? Are you giving nitrates? Are you giving adenosine? Are you giving nitroprusside? Are you giving calcium channel blockers? Are you doing slow inflations? Are you trying not to stent at high pressures? I mean, what do you do to try to enhance patients currently?
Right. That's a great question. I'm going to do the second part first, just about technique and so on, because I want to get more into the first part of the discussion, because I think there was a little bit of a difference for us hearing yours in terms of presentations about what the true unmet clinical needs are. But certainly when it comes to STEMI, my whole approach is trying to get TIMI 3 flow without causing microvascular occlusion. And the biggest challenge I have, even in training young physicians, is to try and get them to stop thinking that, having TIMI 3 flow means you've revascularized the artery. And that's one of the biggest challenges I have, is people see TIMI flow, and they'll call it TIMI 3, but no one talks about blast grades. No one talks enough about how quickly the ST segments resolve. And so I think there's a huge sort of unmet clinical need there. But there are a lot of things we can certainly do in the cath lab. I think the basic things are making sure your patients are on the right antithrombotics before being loaded with antiplatelet agents and using the correct antithrombotics during the procedure. I'm, I guess, of the school of not trying to aggressively post-dilate and embolize thrombus distally. I do still believe there's some role for thrombectomy. It may not be manual aspiration, but it may be with using a device. And I try to potentially undersize. I try to do everything I can in my procedure to not embolize the thrombus distally. So whether that be not pre-dilate if I can see the lesion and try and direct stent more often. But my biggest concern when I do a STEM is not the fact that I'm not going to open up the artery. I'm always going to open up the artery. My biggest concern is, what is the microvascular system going to look like after I've opened up the epicardial artery? And I think for me, that's where I still see in STEMI the biggest unmet clinical need, but a lot of people are just not addressing.
Yeah, so I think if there's one take-home message that I'd like people to get, there's multiple, but one is that I think we're only successful in 50% of primary PCIs. I really do. We can do really better in the other half, and the poor man's way to look at that is the ST segments after the procedure. And you're going to see that in half of the cases, they're only improved a little bit, and actually in about 15% of the cases, they're the same or they're worse. Okay, so in only about 50% of the cases are they at least resolved 70%.
Great. I'm going to interrupt just one second. The intra-aortic balloon pump was thought at one time to help for TIMI flow, slow TIMI flow. Yeah. And some people thought this was a method to do it, mechanically go and sort of force flow down the artery. But I think you're stuck from the arterial side, truthfully.
Exactly.
That is, your ST segments are going to stay there because you don't have any way to get them down further.
Right.
We don't have any tools, pharmacologic or otherwise, to address the antegrade flow. It's stuck. So that, I think, leads this whole field open to the other side, the venous side. Now, it was attempted in the past, way in the past, and now it's coming back, and Dr. Banning's presentation was impressive. But let me ask Dr. Azeem, do you pull out a balloon pump for TIMI 2 or less flow?
Not anymore.
Not anymore. Yeah. Nobody does.
I don't know. Once a time I would. If I was in Europe, I certainly would try Pixo, and I have in the past. And I've seen some incredible results with putting in the Pixo in TIMI 0 flow even. Because let's face it, even then, when we give all these drugs, whether it's nitroprusside, adenosine, whatever epi, whatever your concoction is that you believe helps no reflow, most times all we see is, again, improvement in epicardial flow. It's hard to show true improvement in microvascular flow. I wonder if there's a role for balloon pump, an impeller in some of those situations. I don't know. I mean, maybe that's the basis of the DTU study. But it strikes me that, we've tried lots of drugs that maybe a mechanical factor or mechanical way of trying to deal with microvascular occlusion might be better.
More, let me go on.
Yeah.
So, I mean, I can tell you that, I've done studies of balloon angioplasty, stents, thrombus aspiration, glycoprotein 2b3 inhibitors, Cangalore, intra-aortic balloon pumps, all of these randomized trials, and nothing changes the 50% ST segment resolution. So, and as you were alluding to, if we're stuck in the microvasculature, nothing is going to affect that. At least nothing that we've come up to as of this point. And that's why what's exciting about this potential new therapy is we're getting into microvasculature from the other side, which is pretty interesting. So, Tim?
Yeah, just a couple of comments. So first,
Tim, push your mic again. Azeem, turn your mic off. Thank you. There you go.
Yeah, just a couple of comments. So first, that Greg and I were saying different things. Actually, we're saying the exact opposite. I mean, the exact same thing.
He said the opposite, but he meant the same.
And here's why. So if you look, and I'm pointing out what challenges we have in STEMI, all those things are. So number one, who dies in the hospital or in the first month? It's out-of-hospital cardiac arrest and cardiogenic shock. That's who dies. That's not who ends up with problems.
Right, with heart failure.
So when I'm talking, and that's when I'm getting to the microvascular obstruction, that's the group of people who end up with heart failure. And with all the drugs that we're using, it's not even at 1 year now, it's like 5 years and 10 years. That's where the problem is. And I think MRI points out that very well. We know microvascular obstruction. Problem is MRI doesn't help you at the time of the STEMI. And so I think where a lot of these myocardial preservation studies have failed is because they put in people who are going to do just fine together with people who aren't going to do just fine. So personally, we have the technology now. I think every large anterior infarct should have an IMR. And I agree with Greg that there's a good correlation with ST segment recovery, but not perfect. But why not do both? And certainly, if you have a high IMR and poor ST, that's going to be a group of people that almost always have microvascular obstruction. And so that allows you, right at the time of the PCI, to know who the high-risk patients are.
Yeah. So let me come to Mort. I mean, I will say right now, the Pixo AMI 1 is being done, it's not IMR directed. It's just being done in anterior infarcts in a straight series of patients, non-shock. So, and right now we're planning on Pixo AMI 2, which will be 300 to 400 randomized patients in the United States, also not doing it IMR directed. So, in your opinion, are we at, you gave a 2x2 where you talked about IMR and MVO, but MVO we measure 3 to 5 days. So that's past the point where we can decide to use Pixo or not. We need an in-cath lab point of care measure, and that's potentially IMR. So are we at the point where you are confident enough, you personally, that we should be using IMR to direct which patients we would apply these newer therapies to? And if so, if you believe yes, we really know enough about IMR, where it's on absolutely firm ground because we've got the data in 1,000 patients, tell us what the technique is, how long it takes, pressure wire based, et cetera, and can everybody in this room and another 1,000 people out there do it?
Okay, so I think IMR is well established as a methodology for microvascular disease. That I agree with. In the population of the acute infarcts, I think it's got a limited scope, but I think it still reflects adverse outcomes and a lot of microvascular disease. And I think coupled acutely with the ST segment response might be that to identify those high-risk MVOs, since we can't do MVO by CMR at the time, so I get that. Now, if you're putting in patients that have low IMRs in the setting of an infarct, they're likely not going to benefit. So I would use it as a screening tool right off the bat. If it's low, you're good. You're good to go. It's not a big infarct. The other thing is perhaps the right-sided infarcts are not going to be as impacted by coronary sinus occlusion because they're kind of on the proximal side of that anyway, although you may get the inferior cardiac vein. So yes, everybody can do it. It's not very complicated. The limitation now is in the software available to everybody. It's not in everybody's lab. They have to make an additional purchase. But the wire is not complicated. The injection bolus is not complicated. Last will be to see how complicated it is to do some intervention in the coronary sinus, which may be a little more involved, but you're interventional cardiologist, for God's sakes. If you can't do this, let's hang it up.
Can I ask a question
Yeah, go
in
ahead.
relation to that? So Mort, I agree with you. I think it's going to be a useful tool for us to really find those high-risk patients. But one of the things that struck me is we then treat all these patients the same way, right? We're going to give them 40 minutes of Pixo. Who knows that maybe my patient needs 60 minutes of Pixo or 80 minutes of Pixo? So could IMR also be used as an acute measure of efficacy? So do you think we could, after 40 minutes, re-measure the IMR? Oh no, it's still greater than 40. Why don't we try now giving another 20 minutes? Is there any data to say it could be used as a measure of efficacy?
Not a lick. So the IMR is just a tool used once in the setting of STEMI. None of the information you just asked about is available. In fact, I don't think anybody knows what a good Pixo time is. Maybe we should do it for 24 hours. I have no idea. And will the IMR change? And that one might be a marker of success, real success. You're going to look at the ST segment, make sure you're hemodynamically stable, check the IMR maybe 2 or 3 times over the course of a day. Now remember, that requires some invasive maintenance. That is, if you're going to check IMR now and you're going to check it tomorrow, you got to go back in. And so that's the limitation of this method. But maybe over an hour, I kind of doubt you're going to see much change, but it's possible. Over 3 hours, maybe a little better.
And I didn't more see any IMR data correlating with heart failure yet, or infarct size or LV function.
Well,
So with mortality, we've seen that. But if you remember our data when we looked at MVO by MRI, it's an independent predictor of mortality, but not heart failure. So there's other things that are going on in these patients other than just microvascular obstruction. And one of the relatively exciting aspects of Pixo is that it may be doing more than just microvascular obstruction. It may be having an effect on reperfusion injury, apoptosis, other cardioprotective mechanisms. A lot of that is very hypothetical and just experimental based. Ultimately, we need the randomized data to find out.
So I think MVO and IMR are separate.
Right.
They're not identical. And so you may have a disconnect between the two.
They overlap, but they're not identical.
And infarct size is
Two
the
really
commonality
quick
to all
take-home
these
points for the
tools.
audience for out there. So the technology to look at microvasculature with IMR is now easily available in everybody's lab. And this is looking post-MI, but I would encourage everyone that microvasculature is important for many things. So patients with INOCA and MINOCA, patients with PCI chest pain, HFpEF patients. And so I personally think that IMR should be a standard thing that you do in the lab, and certainly the large anterior infarcts as a patient, I think, personally I think it should be almost routine, but we're not there yet. And then the second point, so that's one thing. How do you look at the microvasculature? But then the second point, I think the Pixo is, this is a trial that's coming up that could really change some of these patients that have large infarcts who are going to do poorly over time. And so and I think this is an important symposium for both those reasons.
So, I'll tell you, I personally think Tim and Mort, respectively, we need a ton more IMR data before this is ready for prime time. We've got randomized data in 12,000 patients of intravascular ultrasound guidance showing 35% reduction in MACE in the DES area. We can't get people to do that. So, people really need extraordinary amount of very convincing data before they're going to change practice and do anything extra, especially in the STEMI setting where there's still a mindset of getting in and getting out.
In the middle of the night.
Tim, one comment I want to ask you about is that, this issue, you showed very nicely that, and you discussed this divorce between getting the patient out of the cath lab, surviving the next hospitalization, and then late heart failure. And then again, as I showed you, the infarcts are large and we are getting a lot of patients with heart failure. But, in the lab, people are saying, I opened the vessel. As Azeem said, they're not being very critical. I'm happy. The patient's chest pain is somewhat down, and I'm done, okay? It's 3 in the morning. It's a 20-minute procedure. How do we get people more aware of this issue, that there's more to be done. You've got to be a better doc than just that. We've got to understand infarct size, microvascular obstruction, the long-term prognosis of the patient, and ventricular function recovery.
So this is such an important point. And we wrote because we have short-term attention spans, and we're all looking at 6-month mortality and 1-year mortality. So just to give you an idea, clear cut, if you have an infarct size over 20, that's bad, right? So we looked at, I don't know, it was about 10 trials that the entry criteria was the average infarct size was 24%. And you know what these are all stem cell studies. You know what the 1-year mortality of those people was? 1%. But that's not that they're not sick. What we've done is with good secondary prevention, we're preventing early mortality, but these are people that are getting heart failure 5 years and 10 years from now. And the problem is our studies don't follow it long enough.
Azeem, I want to give you the last word and see if there's any last questions from the audience.
No, I just wanted to address maybe one of Mort's points, probably being one of the few people in the room who's actually put in a pixel in the middle of the night. It's not that challenging. It's a new technique to learn. You go up with a steerable catheter because you're doing it from the femoral, not from the neck. And being from the femoral can be more challenging cannulating the coronary sinus. But with a steerable catheter and a Terumo wire, you can actually get into it pretty easily after you've been taught how to do this. So I don't think from a technical point of view, it's going to be very challenging to teach sites to do this when we get into the clinical study.
If EP guys can do it, you can do it.
And the nice thing about it, the way the study's running now is you first do a balloon angioplasty. You first get the infarct artery open, so you've met your door to balloon time metrics, the patient starts feeling better, and that's when you establish the PICSO. So it doesn't delay time to reperfusion.
Yeah, I think that's hugely important because, for a lot of centers, the DTU study has been a challenge to get buy-in by our cardiology colleagues because you're leaving the artery closed.
Right.
So you're opening the artery, you're getting some flow, and then you go ahead and manipulate. Yeah.
All right, well, we hope you've really enjoyed this symposium. Again, hopefully later this year, we'll be starting the randomized PICSO-AMI-2 trial in the United States, which would be the pivotal FDA IDE approval study. So we hope if any of you want to be involved as sites, please come up and talk to us or send us an email, talk to your friends, because this is exciting. We still have to continue to improve outcomes, and this is potentially a great way to do it. Thank you, everybody.